Good afternoon. My name is Gabriel Ruiz. I'm one of the trauma surgeons located in Miami, Florida. I work at the Ryder Trauma Center. I see there's a lot of people that I know, some new names. To those that are new and are joining us for the first time, welcome. It's gratifying to see how the crowds get bigger and the interest kind of spreads on seeing some of these cases. To those that don't know the center or what we do here, we're a level 1 trauma center. We take both pediatric and adult trauma. We take also blunt and penetrating trauma. We have a good amount of activations year round, and we traditionally tend to work without much the support of many specialties, as we do most things on our own, and that includes chest surgery, abdominal surgery, vascular work, obviously gastrointestinal trauma. So it's rare that we get, let's say, a vascular injury and we're gonna just consult vascular surgery. And the reason is because it's tradition that we do it, and we have a training program for fellows, and that's the reason we tend to give them the greatest exposure to all the flavors of trauma, so they can be well and rounded trained. I have no disclosures, unfortunately, to do. And for those people that are not used to, maybe not in the medical field, there are some sensitive images on the presentation. All right, so this is the case. This is a patient, a young patient on his early mid-20s who presented to the trauma center a few minutes after being impacted by a high-velocity round in a situation of a shooting incident close to the downtown of the city. The rescue truck called us and told us that they were en route, that the patient was tachycardic and obtunded, that the patient had 4 different gunshot wounds to both legs, that they had applied a tourniquet as they had seen major exsanguination on the field where they picked up the patient, and they had applied a tourniquet on the right thigh. And the picture actually depicts the kind of a schematic of the location of the gunshot wounds and the size of the actual injuries. As you can see, the injuries goes from left to right. There's a gunshot wound lateral on the mid-thigh, a right medial gunshot wound in the thigh as well, on the right side, and on the left side, I'm sorry, and on the right side, there's a bigger wound on the inner thigh, and on the back of the leg, which is that pink circle, there's a major crater, a major injury, and the patient had a tourniquet in place. And this is the presentation. So the patient was moaning. Obviously, I got him intubated. He looked very acute in the sense that he was pale, diaphoretic, having agonal breathing. He was not conscious. He had bilateral breath sounds. His clothing was covered in blood. It was drenched in blood. He was very tachycardic and very, very hypotensive. The first blood pressure that we got actually didn't pick up anything. The subsequent blood pressure had a blood pressure systolic of 40, and he had a massive hematoma on the right side, and he had a tourniquet applied to the groin. So we're going to concentrate on the right leg, which is the leg that actually had most of the damage. But remember that there were injuries also in the contralateral leg on the left side. And on this picture, what I'm trying to depict is the location of the tourniquet, which is that blue rectangle. So it was a tourniquet that was applied very, very proximal on the groin. It was right on the groin. And then you can see the dark circle was a wound on the inner thigh, and the pink circle was posterior on the thigh, a major wound, and both were connected. You could actually put your hand on one side of the wound, and you would feel your fingers coming out of the other side of the leg. This is a young, thin male. So we obviously started the resuscitation. We placed, he had peripherals. So we started massive transfusion protocol. He obviously had no pulse in the right lower extremity, had a massive hematoma in this area. His thigh was twice the size of the contralateral one. On the left side, even though he had 2 injuries that were very similar but smaller, he had pulses present and an ABI of 1.2. Obviously, he was still hypotensive at this point. And on the right side, he had no pulse. Okay, and as we were doing the resuscitation, portable x-rays were here, we had the chance to shoot an x-ray. So I had done first a KUV because I wanted to see if there was any projectiles on the abdomen and a pelvis. There was nothing, but these were the two x-rays that were interesting. And on the right-hand side of the picture, you can see the amount of edema and hematoma that he's got. You see that there's multiple small, tiny ballistic fragments. You see that there's a defect on the soft tissue on the inner side. You see the area where the tourniquet is placed and the massive hematoma distal to the placement of this tourniquet. All right, so my first question, and you guys can help me go around the audience, is how do you approach, we know that this patient has to go to the operating room, right? So we're gonna first resuscitate the patient. There's no emergency to go. Right at that point, we started transfusing the patient blood. We got a blood pressure of 140 after 6 units of blood, 4 of FFP, in a heart rate of 120. So it had improved on his vital signs. And we were on minute 15 or 20 after arrival at this point. I know I have to go to the operating room, and the first question for the group is, how are you going to approach this, knowing that the patient has a junctional tourniquet in the lower extremity, right? So he's got a tourniquet right there where the blue square is, and you get to see the wounds that are distal to them. How are you going to approach this in the operating room in terms of vascular control? And I leave it to the audience. Gary, maybe you can help me go around because I don't have the screen where I can see everyone.
Yes, sir. Let's go to Argentina, Dr. Elvio.
Okay. I prefer the retroperitoneal approach in the groin, over the groin of the external iliac artery by the retroperitoneal approach.
Excellent.
Thank you very much, sir. Mexico, Dr. Vega. Mexico, would you care to comment?
Yeah.
Okay, go ahead, please.
I think we can the approach we can go is to the groin directly, and we can have a proximal control, even cutting the iliac ligament, and make a approach to the proximal in the iliac in a femoral artery, and this stuff too.
Excellent, thank you.
Thank you very much. Baghdad, Dr. Untrat.
Yeah, so I gather that it seems like the blue tourniquet is working, that there's no pulsatile bleeding at present. So if the tourniquet's working, it's right in the way of the inguinal ligament, but I agree, retroperitoneal approach, if you can, and I would just approach it maybe through a lower midline incision, space of Retzi, stay out of the peritoneum if I could, and go to the right. You just need to get control of the right external iliac artery. So, you know, you couldn't make the incision right at the groin the way you ordinarily would to get proximal control at that location. So I would just modify the incision a little bit.
Thank you.
Sir. Portland, Dr. Kasib.
Well, what you're trying to do is when you have a junctional bleed like this, you have to move pretty fast because the patient is going to lose a lot of blood. Trust me, tourniquet in this area is not the norm in many cases because quite often it doesn't work. I'm glad, I'm happy for you that you think that it is going to be working in this particular case, but by and large, tourniquet in the junctional area like this is not going to work. And there are some contraptions available. You know, there are external pressure contraption that have been developed by the military, and in some hospitals they are available to get compression above the inguinal ligament to stop the bleed when somebody is exsanguinating. Now, in terms of vascular approach, I don't like the midline incision and retroperitoneal dissection from there. I think I would just do above inguinal incision and expose the common iliac artery in that area and get a cross clamp applied to this area. And that's what I would do.
Is it just me or did Dr. Kasim lose video? Audio.
No, it was just you. We heard the whole thing. Thank you, Dr. Kasim. That's a very important point. And once we finish going round, I'm going to go back to your point because you raised very, very important points here.
Okay. And Philadelphia, Dr. Alex.
Hi, can you hear me?
Yes, sir. Loud and clear.
I missed a little bit of the presentation at the beginning, but this looks like if I got the story correctly, this looks like a Black Hawk Down type injury. If we watch the movie, the tourniquet didn't help in the movie. And the other thing that we don't know, or maybe it was presented, but because I came late, I don't know what's going on in the abdomen. So if you don't know what's going on in the abdomen, and let's say this tourniquet works, probably to just go midline, then you survey the abdomen and you can get control of the iliac from inside the abdomen. Otherwise, if you're clear about the abdomen and you have no worries with that, then a hockey stick incision retroperitoneum at the area of the inguinal ligament should help in this situation. I think the group from Penn, Dr. Niels Martin, had a similar case probably last year. I remember they talked about the reboa, and they put a reboa in the other leg, inflate the balloon at the level of the umbilicus. That controlled the bleeding. I saw that the ABI on the left lower extremity was normal, so I think that's an option too. I think also the body habitus of the patient is important for any of these approaches. These are my comments. Thank you.
Thank you. Is Dr. Schwartz in Jerusalem still with us?
Yeah, I'm here. Hello, Gabe. What's up?
Oh, nice to hear
hi,
you.
How are you? So I wanted to say also about the reboa, but since it was said already, so I had a patient that had a similar injury, and he was shot by M16, also a high energy gun. And I think I would take the last comment to use a midline incision with laparotomy, because what we found was an injury to the bladder. So these kind of high energy gunshot wounds can surprise us with sharp nails that goes also inside the abdomen and can cause rectal injury and bladder injury. So I would rule it out by midline laparotomy, see that the bladder is fine, the rectum is fine, and then continue just for vascular control from inside the belly. Reboa is also an option, like maybe even from resus, just place the reboa, go to the OR, and then you have control, because this kind of tourniquet may fail on the way.
Thank you, Dr. Schwartz. Any other comments before we return to Dr. Ruiz? Okay, back to you, Dr. Ruiz.
Thank you, Gary. So all of those are really, really extremely important points. Let me go back to a few of them. So for Alex, the wounds were in the upper thigh, and the abdominal exam was normal. He had a little bit of a blast injury on the skin of the scrotum on the right side. The perineum was normal. We did a rectal exam, had no blood. Obviously, the suspicion for abdominal injury, and this is also for Alon, it stays always there, right? This is a high energy round. The soft tissue destruction on the leg is massive. And it's clear that it's something that we kept in mind where this patient had some sort of abdominal injury. Now, the other comment brought up by Dr. Kasim is very important, and actually by Alex too. Sometimes the stars align, the planets align, and the patients had good outcomes just because pure coincidence. The EMT, the first responder, was a former military medic. And he was the one who applied the tourniquet. And when he came in, curiously, he actually mentioned, this is the Black Hawk injury. So I put the tourniquet as high as I could, and I squeezed the tourniquet as hard as I could. It's a big built man, 100-pound guy. So the tourniquet was actually a effective tourniquet. He had completely arrested any bleeding proxima distal to the tourniquet. So I think someone with military training who actually trained with us at Ryder was key on having this tourniquet placed. And I agree with you. These tourniquets may be effective with the patient's blood pressure at 40, but if the patient's blood pressure now is 140, I don't know. So there was an emergency to get to the operating room, and we had surveyed the abdomen anyway for foreign objects on the belly, and the patient was well resuscitated at this point. So this is what I proceeded to do, and I agree with the first one of the surgeons that was said that the retroperitoneal approach would be the approach of that I would elect here, and the reason is because getting into the groin with the tourniquet seemed to me impossible without taking the tourniquet down and knowing that this would be a massive bleed. The second one, which again is one of those planets aligning, I spent some time in the transplant team right before starting my residency, and I got to be familiar with the retroperitoneal exposure for kidney transplant, which exposes the iliac there. And it's clean, it's very fast. I can get this done in 7 minutes to go from the skin to a clamp on the iliac, and it doesn't bleed at all, and it's away from the hematomas, and it's an exposure that I use often on very proximal thigh injuries because it allows you to find the iliac very fast away from the hematoma with zero bleeding. So hockey stick incision. Go through the skin, divide the fascia, be sure that you find your inferior epigastrics and clamp them. I basically just put a couple of hemostats on them. I don't even tie them, just put a couple of hemostats. And do not divide the peritoneum, and then you reflect the peritoneum cephalad, and then you'll see both the iliac artery and the ureters nicely, beautifully exposed. And the other thing that is important is that the body habitus really doesn't have much of an impact here because the retroperitoneum is voided of fat in most patients, except on the massive morbid obesity. So it's really easy. I don't have to get through the abdomen. I don't have to deal with dissection of the colon, mobilize the colon or anything. It's just very fast. And let me see if this is the exposure. So you see exactly how the exposure looks like. The only difference is that I don't do a linear incision. I do a hockey stick incision, and this is because of the transplant experience. And basically you can expose those vessels into the retroperitoneum. So I was able to put a clamp rather quickly. And then we did an incision over the thigh below the tourniquet, and we're able to identify the superficial femoral artery. And this is what we found. He had a transection of the common femoral in the profunda. There was an 8-centimeter gap of on the vessels. It was impressive. And here you see why this patient in the Black Hawk Down event died, because the vessel gets retracted into the groin, and it's impossible to get from the outside. And that's the reason I avoided to explore this directly through the wound or below the inguinal ligament. The femoral vein was also transected, and it was the cause of major bleeding. He had the saphenous nerve transected along with this packet. And the most impressive thing was that there was a large 20-centimeter round cavity of the soft tissue. So most of his quad muscles were completely disintegrated. The superficial muscles and the lateral muscles on the thigh, including the tensor of the fascia lata, was gone. And my hand just could go from the front to the back of the table, my entire fist. So here we go with the next question for the audience. Now that you have vascular control, the patient has normal hemodynamics and no other injuries. By the way, when you do the retroperitoneal dissection, you get to see the bladder, you get to see the peritoneum. There was no hemoperitoneum. There was no penetration into the peritoneal layer. Everything was well below the inguinal ligament, all the injuries, and above the inguinal ligament, there was no injuries. And with this large soft tissue cavity, what do? How are you going to proceed with vascular repair? By this moment, I can tell you that I completely eliminated the possibility of just shunting the patient and taking to the ICU. I think the patient was resuscitated. I said, I'm going to attempt a repair these vessels. But there's the issue of this large soft tissue cavity, which may have implications for the future of this patient in the post-op period. So how are we going to proceed with this vascular repair? And I give it to Gary, so Gary can go around the room.
Yes, sir. Dr. Kassim?
Well, you said that you have completely eliminated shunting procedure. So let me ask you a question first. How much blood have you used so far?
At this point, we had used 7 units of blood and 4 units of FFP. And after we resuscitated the patient in resus and I got control and we went into the OR, there was no blood hanging. And the blood pressure of the patient was into the 140s, 150s with heart rate in the mid 100s. We did send an ABG on arrival and his pH was 6.8 and with a base FCD of -21. The intra-op pH was 7.27 and the base FCD had corrected to -4. So overall, and the patient was making urine. So overall, the patient was well resuscitated at this point.
Right. Okay. So in a case like this, if I'm in the OR, I probably will consider doing a damage control procedure, and this is what I would do, without any hesitation. I would do a shunting of the femoral artery, and then I will try very hard also get some blood perfusion to the profunda with the hope of preserving the profunda for the later use somehow. But while I'm here, I would definitely consider putting an interposition vein graft to the femoral vein. I think it is important to keep the venous flow going. So I would probably either get a long sap or external jugular or antecubital vein or somewhere. Would not use a prosthesis in a situation like this. And I would try to get a continuity of the femoral vein established, since you told me that the femoral vein has been blown off too. And I would temporarily cover this area by moving the sartorius. If the sartorius is still available, if it is not available, I will search for some other alternative to cover this area and get the patient back to the intensive care for further resuscitation with a view to coming back pretty quickly to reestablish vascular continuity with either a graft or something. That's what I would do.
Thank you, Dr. Kassim. Philadelphia, Dr. Alex.
Big problem here, but I think there is some time to think. I think I would go with the shunt, wash, irrigate, clean the wound, kind of assess how contaminated it is. I would call for some help, either somebody more experienced with vascular injuries, and definitely a vascular surgeon. The options are either for reconstruction here to put a PTFE ring graft in the tissue where the injury is and reimplant the profunda after you reconstruct. If it's too much contamination and just looks like it's asking for trouble, then you may have to, I guess, switch the bifurcation and just tunnel from the contralateral leg a PTFE graft to restore the flow in the SFA on the right lower extremity. And then for tissue coverage, I used the sartorius as a flap in the past. I hope that would be still available to use it. If not, as Dr. Kassim said, some other tissue. If it's too bad that there's really no tissue, maybe I'll just reach out to plastics to help with the gracilis flap to cover. These are my comments. Thank you.
Thank you, Dr. Alex. Jerusalem, Dr. Schwartz.
So I will definitely call for help. This is not a question, Ivan. But this idea to take a PTFE graft from the other leg, a bypass graft, this is a great idea. But probably I will try to prevent the use of any artificial grafts and use just maybe saphenous from the other leg as a bridge. Probably will tie the profunda femoralis and do a bridging with the saphenous from the left leg for the SFA. This is what I will choose, and of course fasciotomy, large fasciotomy of the cuff for compartment, and all the previous comments about putting muscle, sartorius, or even rectus abdominis on the soft tissue reconstruction. Thank you.
Thank you, Dr. Schwartz. Mexico, Dr. Vega, your comments, please.
I agree with try to restore the viability of the vein first, and then the artery. And I'm agree with try to put as a graft later on there, and to see what's the viability of the muscles, to see what happened with the cover. That's my comment. If there is no place for a damage control right now, we can do it in the first scenario.
Thank you, Dr. Vega. Baghdad, Dr. Untrak, your comments, please.
Yeah, so yeah, I would be inclined to do an extra anatomic bypass like Dr. Alex and a few others said from the left groin, assuming that the wound is not contaminated there, and stay out of the area of the current wound, so across the pubic symphysis and down the medial thigh, anastomose distal in the SFA, and try to also revascularize the profunda, probably with a piece of saphenous vein from the toe of the graft. And I think in this case, probably, I would call in the vascular guys, see what they thought, but I think probably in that case I would use a graft, but staying out of the wound, and then deal with the wound later. About the venous drainage, I'm concerned about that also, and I would have to defer to the vascular people about putting in an interposition graft in the wound, whether that would work, or and certainly the fasciotomy would, in this case, I agree, would be critical, because the leg will swell without adequate venous drainage. But I would favor the extra anatomic approach in this case to restore blood flow, arterial flow.
Thank you, Dr. Untrak. Dr. LVO, thank you for your patience. We await your comments, sir.
Okay. First of all, I will use two shunts, one for the vein and one for the artery, and just start thinking which is the best solution. I don't like to perform extra anatomical bypass from the left groin, because if you have an infection, you will have two groins infected. So I will try to perform an external iliac bypass for the right groin to the femoral with PTFE, or if I have just a little piece of common femoral artery, I will try to perform a venous saphenous vein bypass from the left limb. After that, reattach the femoral profunda artery. And in the last surgery, I would try to reconstruct the femoral vein. And after all, just put a sartorius.
Thank you very much, sir. Any other comments before we return to Dr. Ruiz? Okay, back to you, Dr. Ruiz.
Thank you very much, Gary. It's incredible how these conversations that we have in today happened that day as well. Every single one of the points that were raised by the different surgeons here in the audience were actually discussed one by one. The first one, so the green circle depicts the area of massive destruction of tissue. So there was no structures that you could identify within the green circle of injury. The takeoff of the profunda was completely gone. I couldn't even find where the profunda was going. All I could see were 2 or 3 different perforators into the quad muscle, but I couldn't really identify anything that could resemble a profunda vessel. That was the amount of destruction. The femoral artery, the SFA, and part of the common femoral was completely gone. There were no remnants of it. There was no tissue or anything like that, and it had been replaced by an empty cavity with hematoma that we cleaned up. Same with the vein. On the vein, what we saw was that there was a distal femoral vein that we could clearly identify within the muscle, but we could not see any remnants of the vein or any sort of the structure, and we could identify the 2 ends of the vein with a gap of about 8 centimeters. The green circle had a lot of muscle that was either blasted, that you could see with some hemorrhage, but not major damage. The only tract that the patient had, the only area where the patient had no injury was in the posterior muscles of the thigh. So behind the femur, which was not broken, by the way, behind the femur, there was muscle that looked intact. But most things above the femur, and especially the lateral muscles of the femur, were of the thigh, were completely gone. The sartorius muscle was actually intact, and it didn't look blasted for some reason that I still don't understand. But the deep muscles of the leg were gone. Basically, this was an empty cavity. I could basically look and see to the other side. Now we discussed repairing the vein, and this has been an area of permanent discussion amongst attendings, both vascular surgery and trauma surgery, for the longest time since I've been here. And I can tell you that in this setting of vascular injury, most of our vein repairs have failed. And the only thing that we had left is an extraordinary amount of time dedicated to reconstruct the veins, done by the vascular surgeons, done by the trauma surgeons, and most of these procedures have been unsuccessful. There's just a few handful of cases that we have successfully repaired a vein and not have a posterior thrombosis of the vein, or including complications from the vein repair, and it's a procedure that takes time. I personally don't do it. If there's any thought of vein repair, I call vascular surgery, because I know that these things are more difficult than they seem to be. And obviously, they are never done with PTFE. They're always done with saphenous vein, but they usually fail. So our tradition and all the discussions have gone into an area in which, if there's combined injury of the vessels in the thigh, femoral, we tie the femoral vein. We just go ahead and tie the femoral vein. We don't even consider reconstructing, especially if we're in a damage control mode, because it takes a long time. Even the shunts on the vein, they usually fall within the next 24 hours. We see that there's failure of the shunt on the vein. So we don't even spend time on this. And I know there's controversy, but I can tell you that this has been a subject of permanent discussion for the last good 10 or 15 years that I've been here. Now the second point. So an extra anatomic bypass from one groin to the other is something that I would probably consider on a delayed fashion, but we usually don't do it. We usually don't do it, especially because if you're suspecting that this cavity will be infected at one point, and you're gonna bring a jump graft from one side to the other. I agree with the vascular surgeon in Argentina. You will be infecting 2 different cavities, 2 different vessels, and you'll have bilateral problems at this point. So we tend to deal with the unilateral injury. So that left me, and there's no way to tunnel this graft posteriorly and come back out on the other side of the leg, something that we also discussed. What if we try to put a bypass and tunnel the bypass on the muscle? That looks viable, but it seemed something crazy to do at that point. I don't know if someone would think about this, and I would love to hear how would that be done. Anyway, so we've had good outcomes with PTFE, direct bypass graft, even in large areas of cavity, as long as good wound care is done, and a very judicious surveillance is done, and we have had good success. So this is the route that we decided to do. We ligated the femoral vein. Every time I do a vascular repair on somebody who's had a tourniquet or somebody who's been on significant amount of shock, I have this habit of passing a Fogarty once or twice, just to be sure that I'm not leaving anything behind on the distal side. We placed a PTFE graft, and ended up being 12 centimeters of PTA graft after we debrided the vessels. And we were lucky enough to be able to do a muscular transposition. So basically what I did was mobilize the entire sartorium. I actually had to divide part of the sartorium distal in the thigh, so I could have enough flexibility and do it actually around the spinosus, which is a deep muscle in the thigh, and kind of sandwich the entire graft on these two muscles that look viable. I agree with those that suggested doing 4 compartment fasciotomy is something that I always do if there's combined arterial and venous injury, and we have decided not to go for the vascular repair. This picture shows the muscles that I mobilized in order to cover the graft, and I was able, and I was lucky enough to be able to cover 100% of the graft between the sartorius and between the acetospinosus, the pectineus muscle, and the adductor longus of the thigh, all deep muscles in the thigh. The rectus femoris on the lateral side was completely gone, but I was able to create an area in which the cavity was not connected to these muscles, so kind of keep it away from this. But here comes the next part. I finished my repair, and I'll do it always the same. As I was trained by my vascular surgeon mentors, we back bleed, we do everything by the book. We never take a suture from the outside into the vessel. We always tack the intima. We examine the intima very well before we do any graft. But I put my graft, and I have no pulses, no signals, and the perfusion seems sluggish after repair. So my question is, how do you approach this? And this picture kind of depicts everything. So again, as I said, there was no profunda to find, and we did a good exam on this. We had the muscles splayed open basically by the bullet wound. There was no profunda to do anything about the profunda, just a few 1 millimeter perforators all over the place. The graft is in place, that's the white square. There's great pulses at the iliac, there's great pulses at the femoral, there's a really great pulse beyond the anastomosis, but the pulses palpable can start to get faint in the popliteal fossa, and on the foot there's no pulses, and there's no signals on the foot, and I feel a very biphasic signal on the popliteal. This is a 22-year-old patient. That's very important to remember. This is a very young kid. What do you guys do? How do you guys approach this? Is this the time to start making phone calls at this point, which I tell you I did. I started making phone calls at this point. Are you going to investigate? Are you going to take down the entire graft and redo it? How are you going to approach this?
Dr. Untract, your comments, please.
Yes, so I assume that his general condition is satisfactory. He's not acidotic, he's not coagulopathic, and that you can persist in trying to solve the problem, because there's not damage control any longer. And if that's the case, then I would go through the typical maneuvers after a vascular reconstruction. So first, I guess I would try to do an on-table arteriogram, see what's happening. There may be, after you pass the Fogarty, while you're doing you had clamps, and that he may have clotted again. And by the way, I don't recall if you mentioned that you injected heparin distally when you passed the Fogarty, if you heparinized at least locally distally. So it might be that, and or I might go right to opening the easier anastomosis, maybe proximally, if it was more accessible, pass a Fogarty, see if you got clots back, and then And then once you clear the distal outflow, go ahead and do an arteriogram through the proximal, where you pass the fogarty, to see that, be sure that anatomically everything is okay. And then if you weren't heparinized before, I would heparinize distally, just locally, not systemically, and then try again. But I would basically do the typical maneuvers after an elective vascular procedure, assuming that the patient's condition allowed you to proceed with them more definitively in this case, rather than damage control.
Yeah, to answer your questions, so the patient was well resuscitated. He was warm. He was not getting any transfusions for now an hour and a half, and sustaining his blood pressure. His vein deficit was corrected. So there was time to call the specialist. There was time to do the diagnostic procedures. There was time to even think about taking this down and doing it all over again if that was the need. So yes, he was resuscitated. And the other thing is, yes, I usually give the patients, unless there's other injuries, if this is an isolated injury, as soon as I put the clamps, the proximal and distal control, I give the patients IV heparin. This is something that I got trained with both in vascular and in transplant surgery before doing my residency, to operate on heparin. And I injected heparin distal when we put the fogarty as well, because I'm always afraid that something's going to be just pushed even lower down and it's going to be impossible to take. So I always take all the precautions. Now, if there's other injuries, obviously I don't inject the systemic heparin, but in an isolated injury, as soon as I have distal and proximal control, I heparinize the patient completely before we do the repairs.
Mm-hmm. Thank you. Argentina, Dr. Elvio.
Well, I don't like to work to perform vascular reconstruction without heparin. And if the patient it's okay, there's no brain damage, I will use systemical heparin, maybe 5,000 units. And if I have some suspect or another injuries, I will perform local heparin. And if I don't have any pulses after the reconstruction, I will perform an angiogram in the OR using my C-arm X-ray machine.
Thank you very much. Let's go to Dr. I'm sorry. Go ahead, please.
It's very common in young population, the vascular spam. It's very, very common.
Mm-hmm. Thank you, Dr. Elvio. Dr. Kasim?
My teacher taught me, when you have a failure like this immediately after reconstruction, by and large, it is technical. So I don't want to say that to you, Dr. Ruiz. You probably are a marvelous surgeon, which
no,
you
it's fair. It's totally fair. It's totally fair.
So I would keep that in mind, that it is something that I have done. And I need to keep that in mind. Start there first. Hey, it is technical. So now what else could it be? And I agree with Dr. Untrak. I would do an on-table angiogram to see what things look like. And sometimes the distal vessel go into intense spasm, especially in young people, because they got a lot of hormone secreting, I guess. And I would probably utilize piperine in this case, give it a shot to see if I can alleviate the spasms of the vessels distally. And if the angiogram doesn't show anything distally to the vascular tree, then I am compelled to take it down and redo it. Because after all, this is a young person, like you said, and his limb is being threatened. His life is not threatened yet, but I think his limb is definitely threatened, and I would try very much to see if I can salvage this limb. That's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Alex, Philadelphia.
So it sounds like you did everything right with regards to the anastomosis, the PTFE graft, and you paid attention and look at the intima. And I agree with Dr. Kasim, and I also have a tendency, if something is not going well, I like to think, is it something I did wrong, and what could that be? To take down, let's say, the distal part of the anastomosis and you have a flap proximal, then you took down the wrong end. So what I think I would do here is make a small transverse opening into the graft, pass Fogarty up and down if I'm worried that something is not flowing well. That would be easier to close with a few interrupteds. Or, what my other colleagues said, to just do an angiogram. You do an angiogram, but then you would have to stick in normal vessel. So you get, I guess you can stick in the middle of the graft and pass the catheter up, and then you kind of get the picture of both anastomosis. So these are the options. And then if you're sure that there is no intimal flap and your fasciotomy is done well and, the compartments are soft, then you can just go home and sleep well with the papaverine infused for spasm. Thank you.
Thank you, Dr. Alex. Dr. Schwartz in Jerusalem, your comment, sir?
Yeah, I think I have nothing to add to all the other comments that were said already, but the angiogram is a good idea.
Thank you very much. Let's go to Mexico. Dr. Vega, your comments, please.
Yes, first of all, we have to review what we do it with our repair, and if everything is okay, you can make an angiogram. That's my comment.
Thank you, Dr. Thank you very much, sir. Anyone else before we return to Dr. Ruiz? Okay, back to you, Dr. Ruiz.
All right, so all of those, so the first thing that I did when something like this happens to me, the first thing that I do is I blame the fellow. I blame the fellow. Something technical must have happened. So that's the first step. Something technical happened. We maybe took the intima. We may have not done a proper thrombectomy on this patient. Did we actually inject? What you gave me was actually heparin to inject, and all these questions go the first time. And then once I settled down and my tachycardia got a little bit better, then what I decided to do was an on-table angiogram, just like everyone has suggested here. So find out exactly what happened. An on-table angiogram is going to answer most of the questions, whether this is a technical failure or whether there's any other reason. So we did puncture. This was not an arteriotomy, actually. It was a puncture on the proximal artery. And we placed a small catheter and we brought the C-arm and we shot an angiogram. And what we saw was that there was contrast going through the graft, both distal and proximal, without any strictures. So there was no issues on the vessel. There was no areas of dissection. The contrast would go through the popliteal artery completely clean, no clots whatsoever. The trifurcation was intact. However, there was very, very slow contrast flow beyond the trifurcation. Very, very slow. We would have to go with and keep on pushing contrast and slowly go with the CR, but then as my tachycardia was becoming an arrhythmia, see that the contrast was slowly getting into the ankle and into the foot, and the entire plantar arch at the end of maybe 5 minutes of waiting, completely perfused, and it was, I never seen it like that. So I started picking up the phone. So I called a couple of people that I trust, that I know they have gone through these things before. And this is the answer that I have from one of them. He said, it's okay. It's okay. Do nothing. He's got angiospasm. How old is the patient? He's 23. It's okay. Then I called the vascular surgeon, and the vascular surgeon said the same thing. He goes, my patients are usually older, but every now and then we do younger patients. They go in severe vasospasm, especially if they've been in shock. Did you document that he has perfusion on angio all the way down? And I said, yes, it's documented. He said, it's okay. Close and go to sleep. All right. So what to do at that point? What would you guys do? Would you guys continue to persist, take the advice of the older, wiser people, take the patient to the ICU, start some anticoagulation, not to do it, papaverine drip. What would you do? We don't have much time to continue. I don't want to keep you guys longer than what is needed, but this was our surgical plan. So we decided to do nothing in terms of surgeries. We packed the wounds and took the patient to the ICU. I usually put my patients on antiplatelets for 30 days. I do not anticoagulate my patients, to be honest with you, and there's a lot of controversy, even within my own department. Some anticoagulate, some don't, some put heparin drips at a fixed rate, some don't, some use dextran, some don't, some use aspirin, etc. Is there as many answers as you ask? I put my patients on aspirin, so I said, okay, I'm just gonna do this as I do it routinely. I started my patient on aspirin, they get the first dose intrarectal because they're intubated, and as soon as they get extubated, they continue taking aspirin. Very key and important to warm the leg, so we started warming the leg up actively and hourly pulse checks, and this is something that I did for the rest of the night. I didn't go to bed because I just couldn't bring myself. I still had tachycardia about this whole situation, especially going to the ICU, and I started checking the patient. The next day, I went home, the leg was perfused, but I still couldn't get signals. I got a phone call at 3 p.m. that day and said, we got signals on the foot. The foot looks actually very pink. The following day, the first thing that I did was go and check my patient, and he had strong signals, no pulses yet. 72 hours later, he had pulses, perfect bounding pulses. The patient did actually very well. I did most of the dressing changes initially just to be sure that we were not putting dressings on top of the graft. We only had a couple of complications. One of them was kind of a retained hematoma that we took to the operating room and cleaned up in the operating room. The graft was still covered with muscle. They never saw the graft, which is what I was expecting, that we could not see the graft floating into the wound. The patient did have a PE on post of day 16, and I think this is a good point of discussion. I ligated this femoral vein, and I'm suspicious that this ligation of the femoral vein had something to do with this patient having a PE. It ended up being quite subclinical. It was just a good suspicion from one of my partners that saw the patient become a little bit more tachycardic than usual and decided to do a CTA, and they found a small PE. The patient is now fully anticoagulated, doing well. These are some of the wounds, and pardon the salad there because that was supposed to be replaced with something else, but I forgot. On the uppers, the big picture on the side is the internal size in the medial thigh, the size of the crater on the medial side, so you guys can have kind of an idea. The hole on the lateral side is even bigger. And on the upper right picture, you see the left leg, which had also a cavity that healed well. He's waiting to undergo split thickness skin graft this week. His neurological deficits are not major, to be honest with you. He has some sensation deficits, but he's able to ambulate on his leg with a little limp, and has not shown any infections. We've gotten blood cultures in a kind of a routine basis and had imaging a couple of times, never had fluid on the graft, everything remained clean, and the wounds are now pretty much closed. And with that, I leave you to see if there's any final comments. This was just to illustrate kind of the agony of the patient, followed by the agony of the surgeon when things don't turn out as you expect, and how to how to approach something that I had never seen before, which was this major vasospasm on a young patient after vascular repair. And thank you very much, everyone. And I expect to see you guys soon. I think I have a couple or more interesting cases, so I might see you in the next few weeks with another presentation.
Hey, Dr. Ruiz, would you like final comments from the group, sir?
Yeah. If there's final comments, I'll be glad to hear. If there are any other ideas, obviously, like getting the femoral vein did have consequences, and up to today, I believe that it had a consequence. So this is not settled science for me yet, and it's something that I'm looking forward to hear any other ideas. The concept of damage control performing a shunt is also an interesting one that I think I could have gone that way too, without being at fault. But yeah, I'd be happy to hear if there's any final comments.
Great. Dr. Vega in Mexico, your final comments, please.
Great case, Gabriel. I think that we see patients, no injuries only, and so patients is a patients is a sentimental way to do things, and we have to wait for some patients to for the things happen. And thank you very much for your case.
Thank you for your comments, Dr. Vega. Philadelphia, Dr. Alex.
Thank you for sharing this case. I learned a lot. Excellent care and outcome. Thank you.
Thank you. Dr. Elvio, Argentina, your comments, please.
No comments. Congratulations for the surgical team, and thank you for the invitation. It's an honor to be with us.
Thank you, sir. Please, we look forward to seeing you again. Baghdad, Dr. Untrak.
Yes, I would be inclined to think that the pulmonary embolism just came from the patient being immobilized, more likely the other extremity, because there's no venous return any longer from the through the femoral vein on the right side. And so I would just consider this, you know, just as a result of the trauma. So, but it's kind of moot anyway. And as far as the outflow, it looked like you had 3 vessel runoff, that the perineal artery petered off distally, but 2 patent vessels. I mean, you know, the vascular guys, I don't think would, you know, they wouldn't do anything for that. And, you know, so I wouldn't worry about it, but beautiful case. And very nicely, you know, your comments about the approach, the anatomy, the incision, all very illuminating. So it's an excellent case and well presented. Thank you.
Thank you, Dr. Untrak. Dr. Schwartz in Jerusalem, your comments, sir.
Yes, so Gabe, congratulations for the case. About the venous, the ligation of the femoral vein, I probably would do the same. And no one guaranteed that if you would do a reconstruction, the patient won't have a PE also. So probably the consequences were the same. And you were always a role model for me about caring the patient. And I'm sure that changing the dressing by yourself helped the graft survive. I have no doubt. So continue to be a role model, and thank you for the sharing the presentation.
Thank you, Dr. Schwartz. Dr. Kasim, your comments, please.
I will echo the same thing. I think you're one hell of a surgeon. You know, I learned a lot from you today. You know, how to discipline yourself, how to think about the problems when you are tachycardic, and all those are very, very important things to learn from a master surgeon like you. I would like to tell you that I have deployed a drug-eluting stent in the femoral vein temporarily with a view to reconstructing back afterwards. And I've had a couple of cases like that, and I've been successful. And I also want to tell you that if you do ligate the vein, you get proximal propagation of the clot, not necessarily coming from the other leg, from the same leg. You know, the clot just forms on top of where you have ligated, and you will be faced with the possibility of PE at a later date. So anticoagulation in situations like that probably help. And I think you saved this man's leg through your own diligence and methodical application of all the details, including dressing changes by yourself and all that. Those are really exemplary. That's something that you can teach anybody. You just have to watch the surgeon, what he's doing, and learn from it. I certainly learned a lot from you today. Thank you.
Thank you for your comments, Dr. Kasim. Dr. Machado, do you have any final comments?
Oh, Gabriel, great case. And you follow the tradition of the surgeons that used to be in bullfighting and bull ring fighting. This is a very similar bullfight, bullhorn injury that master surgeons would be invited just to be present when the matador would be gored by the bull. Great case.
Thank you, Dr. Machado. Any
Thank you.
I'm sorry.
Thank you, everyone. It's an honor to hear from you guys, and it is I who learn constantly. You probably not remember I was kind of in the shadows when I was in training, listening to all these meetings and listening to the people with experience, listen to the older and wiser surgeons, and now I have the chance to bring a case or two. This is more than an honor. Thank you very much, and I hope to see you next week. I'll be here.
Thank you for presenting, Dr. Ruiz. Thanks to all our participants for joining us, and we look forward to seeing you again at the next meeting. Take good care of yourselves.